Good morning, students. Helen here. I hope you had a great Thanksgiving and a good weekend as well. I want to record this review session for you so that you can get ready for your ATI proctored assessment, which is coming up next Monday. I know we don't have much time and we don't have a class as such to really go over these topics that I had given you to review. I know we are going to meet on Wednesday between 12 and 1, but that is not enough time to go over all of these topics. So I'll try to do as much as I can with the topics to review for your ATI final exam. And I think I could do about a page and a half today, and then maybe there may be less than a page of topics to cover. Probably I will do it on Wednesday or do another recorded session. Let's see how it goes. But if you have any questions, you can always email it to me. You know my email address, and if you need to call me, my number is 240-688-1586. I'm going to upload this video in YouTube and try to give you the link, and then you can watch it. And of course, after that, I will delete it. Now, let's go on to the different topics. The first one is management of care. And under that, we have several subtopics. And so the first one is talking about advanced directives, which is legal responsibilities, and particularly about providing information about durable power of attorney. Advanced directives basically help communicate the client's wishes regarding end-of-life care, should the client become unable to do so. And so particularly the durable power of attorney for healthcare, this is a document in which the client designates a person, like a healthcare proxy, to make healthcare decisions for them if they are unable to do so. And so this is particularly when the patient comes to the hospital at the time of admission, you want to check if they have any advanced directives. And it's always good to have a copy. So the hospital necessitates that to have a copy in the electronic medical record or in the chart, hard copy. And so you need to follow up and check on that. And also you need to remember that unless the provider writes a DNR or gives specific instructions like that, the nurse should initiate CPR. We consider it as a full code unless you have specifics about not doing anything according to the client's wishes. This information needs to be passed on to all members of the healthcare team. Now, I see that you do have some application exercise questions at the end of the chapter 2. This is chapter, chapter 4 in your ATI book. So if you can, try to do those questions there as well. Going on to the next one, which talks about delegation and supervision. Let me look at that page. So we talked about delegation and how it's the process of transferring the performance of a task to another member of the healthcare team while you're still retaining the accountability for the outcome. And so it's so very important that you delegate it correctly and accurately without any potential for harm. So I'm sure you know the 5 rights of delegation, and it's important to remember them as you delegate: the right task, right circumstances, right person, right direction and communication of the task, and right supervision and evaluation. So when you're delegating a task, you want to make sure that you delegate it to the right person. It could be a tech, an assistive personnel, or to the PN as the leader of the team. Also, you want to delegate the right tasks as well. You can assign a major task which a PN or a RN should only do to assistive personnel. So remember that when you're delegating it, you want to remember if the person has the knowledge and the skill and the education and training and experience to complete that task. So that goes on with all of the different 5 rights. You also definitely want to know some of the tasks that you can assign to the PNs and the assistive personnel. To the PNs, of course, we said they could definitely take care of a stable client and do the different procedures and give medications and monitor findings. But if they need to get back to the RN on an ongoing assessment, they need to. Things that they cannot do are the initial assessments, the evaluation, an important discharge teaching, and things like that. And also in some of the states about IV medications, they are especially about IV push. So you want to remember all of that when you're delegating to the PNs. But definitely, apart from that, they can do different procedures like tracheostomy, catheterization, enteral tube feeds, medications. I already mentioned about the IV push and IV medications in some states, which they're not allowed to. But everything else, a PN should be able to do, except for the initial assessment and evaluation and things like that. And assisted personnel, of course, they can definitely do activities of daily living like bathing, grooming, toileting, ambulating, and also the routine tasks, which are there for a patient. So that's what you want to remember about delegation, especially to assistive personnel, and the tasks that you want to give to them, and what you need to remember when you're delegating. So you want to know the predictability of the outcome, how complex the care is, and is judgment essential while performing the task? Things like that you definitely want to remember when you delegate. The next is about confidentiality, and particularly about the HIPAA. So this is a federal law, as you know, and this basically deals with keeping the patient's information confidential, patient's health information. So we are accountable and responsible for ensuring that the information of the patient is not shared with to unauthorized people. So remember, even if it's in an electronic health record, it's important that you protect the privacy of that information that is there. Only healthcare team members who are directly responsible for the client's care may access the client's record. And but the client, of course, has a right to read and obtain a copy. It definitely needs to be kept in a secure area. It needs to be password protected, and you cannot share your passwords. You cannot share information to in social media or in any other places to anyone else apart from the essential healthcare providers and also whom the client wants to share it with. So that's about confidentiality, and it is a federal law. Going on to continuity of care, which is admission, transfers, and discharge. Let me see that. So, admission, discharge, providing continuity of care. Yes, so you want to remember that definitely discharge planning starts off when the patient is admitted in the hospital. So you definitely want to remember that, and not only just before discharge. And when a patient gets discharged, there needs to be continuity of care. So when you're discharging a client, you want to make sure that this all the documents are complete, first of all, and then they are given certain documents to take home, like the discharge summary or the written instructions, which you definitely need to um, go over step-by-step instructions for procedures to be done at home, the precautions to take, what kind of medications, what kind of diet to eat, and what kind of signs and symptoms of complications that they need to report immediately to, whom they need to go, how do they need to follow up, which doctor or which service that they need to go to, and if they need to come back to see a particular doctor in the hospital, you need to give that information as well. So it's very important that documentation is done accurately when they are in the hospital, and when they are going home, you definitely need to make sure that they are knowledgeable, they know how to care for themselves as they go home. Even when they're being transferred from one unit to another or from one hospital to another, it's very important that we give a transfer report, a verbal transfer report in person or via telephone is very important, so that the client's care will be continued without any problems, and there will not be any uh, um, issues with that. Again, documentation needs to be complete before you transfer a patient, and all the healthcare team members then will be on the same page, and they will be able to continue the care without any issues. I think that is basically it about providing continuity of care. Of course, just briefly about admission. When a patient comes to the hospital, you definitely want to introduce yourself, your role, and the roles of other healthcare team members as they're going to come and visit the patient. You also want to orient the patient to the room and to the unit that they are in. You're going to assess them and collect data. And of course, they definitely need to have the identification band, which identifies the patient, and if any allergies, then you may have to have the allergy band as well. So then it goes on from there, the assessment, collection of data, interview, entering information and documenting those, and then so that everybody knows what's happening, the information about the patient, and they will be able to provide the care accurately and adequately. So that's about admission, transfers, and discharge. But particularly, the question was about providing continuity of care, and so you want to definitely remember about that aspect of it. Going on to client education, establishing priorities, discharge planning for client who has diabetes mellitus. So when you are discharging a patient, I already talked about how important it is to prepare them for that discharge from day one. And also, particularly before they leave, you're going to give them step-by-step instructions. But for a patient with diabetes mellitus who may have to continue the care at home in terms of monitoring their glucose, or taking insulins by themselves, or if a family member or another caregiver was going to do that, you definitely need to get them ready. So assessment is important as to what you need to teach them, and whom you need to teach it to. And so then you definitely need to review these instructions with them, the procedure itself. You need to review step by step, and also have them to do a written demonstration. There's something called as teach back method. So after you have taught them, you want them to teach you back so that you're sure that they understood everything that you have said. So anything about dietary restrictions and about the skill that they need to know in terms of checking sugars or administering insulin, you definitely need to teach them and make sure that they are well prepared before they leave and discharge, before they're discharged to home. Critical thinking and clinical judgment, prioritizing client care. So that's the next one. We know that it is very important to prioritize client care. I've given you examples in the class as to how, when there are different types of patients, how would you, in different scenarios, and how you need to prioritize. So you want to apply your nursing process in that as well, because you need to definitely assess and collect the data and analyze, and then see who need to be seen first. How would you establish those priorities when you know that when you know their needs particularly? So in terms of establishing priorities, we already talked about how you need to remember the Maslow's hierarchy, where physiological needs come first, and when it is physiological needs, then you need to remember about ABCs, which are airway, breathing, circulation. So that'll be a priority under physiological needs. You always need to make sure that you are using your critical thinking skills and make a right clinical judgment after analyzing the facts. So that's something that you definitely want to remember, because critical thinking includes problem solving, decision making, and making sure that the outcomes would be the best for the patient. Going on to informed consent, that takes us back to legal responsibilities. So informed consent, again, is an important process. It's a legal process by which a client or the client's legally appointed designee has given written permission for a procedure or treatment. So you need to, for example, just blood transfusion or an invasive procedure, you need to get the permission from the patient or the designee, and they have to sign before that particular procedure is done. So that when they're giving that informed consent, you have whoever, if the doctor basically gets the consent, the nurse stands as a witness. The role of a nurse is to witness the client's signature and to ensure that the provider has obtained the informed consent responsibly. If the patient is still not very aware of the procedure or not comfortable with what's going to happen to him, you can always call back, be the patient's advocate, call the provider and tell them to explain it one more time. But you definitely are there to just witness, to make sure that that consent is obtained. When the consent is obtained, they will explain the risks involved and how the treatment and procedure will benefit the client, why the client needs that particular procedure, and also the other options that are out there. So all clients must consent to the care that they receive in a healthcare facility. Okay, so the responsibilities in informed client is the provider obtains the informed consent. The client gives the informed consent, and the nurse witnesses the informed consent. So that's what you want to remember. So state laws prescribe who's able to give informed consent. And of course, in emergencies, the laws may vary a little bit, but Otherwise, in usual circumstances, a competent adult must sign the form for informed consent. And as I said, it could be patient or it could be a designee. But for a minor, it could be, again, the parents or a legal guardian. So again, remember that it's important that informed consent needs to be obtained. Identifying resources under information technology. Again, I guess I do not know exactly the question that is going to be asked on that, but when it comes under information technology, we need to be aware that there are different sources out there, and we need to be responsible to make sure that the information that we have, the healthcare information that we have about a patient, needs to be confidentially maintained. There needs to be information security. So security protocols need to be in place. There needs to be precautions about social media. We cannot use social networking media in clinical settings, and can post information about the facility or anything that happens in the healthcare setting in social media. There are different again, there are different ways by which documentation could be done, but again, maintaining all of this, I guess, would help with identifying the sources and maintaining confidentiality. I see 65.4% have answered this particular question correctly, so I guess it's not a very bad question. But these are the things that, as long as you know legal responsibilities and knowing that there are different resources which you need to look into for maintaining confidentiality and abiding by the law, then I think we should be covered. Okay, the next one is identifying an intentional tort. This again comes under the section of legal responsibilities, and you all are very familiar with this. There are different torts, so you definitely want to know an intentional tort and an unintentional tort. So this question is particularly asking about an intentional tort. An intentional tort, there are three types: assault, battery, and false imprisonment. Assault is the way, it's basically a threat, probably. Like an example is a nurse threatening to place an NG tube in a patient who's refusing to eat. And so again, here your book says the conduct of one person makes another person fearful and apprehensive. So that was the example. You're kind of threatening. Battery is when you really touch the patient. Intentional and wrongful physical contact with a person that involves an injury or offensive contact. So the patient doesn't want a particular injection or medication. You're trying to restrain the patient, maybe a physical hold, and then trying to give that injection. So that is battery. False imprisonment. A person is confined or restrained against his will. So here, a nurse uses restraints to prevent the client from leaving the healthcare facility. So that is false imprisonment. We'll talk about restraints a little later, but then these are when it's not medically necessitated, when a nurse is either threatening or wrongfully holding on or touching a patient to do something against his wishes, or imprisoning a person by restraining them. All these are intentional thoughts. Of course, unintentional thoughts are negligence, malpractice, and quasi-intentional thoughts are defamation of character and breach of confidentiality. But I don't think there are questions on that, but I just wanted to cover that. You particularly definitely want to know about battery, assault, and false imprisonment. Going on to the next one about application of restraints. You want to, we talked about false imprisonment, where you try to apply restraints, not because the patient is going to cause self-harm, or, for example, patient is restrained medically necessitated when he tries to pull his IV tube or the NG tube, and so that is when it's required. Sometimes we may have to do that to protect the patient, so that the patient is safe and he doesn't pull off his tracheostomy tube or IV tubings like that. But otherwise, if it's really you're doing it for your own convenience, then that is when it is wrong. In terms of application of restraints, what we need to remember is, of course, explain the need for the restraints to the client, family members. Especially if the client is confused, then you definitely want to tell the family members, emphasizing that it's mainly for their safety and it's temporary. And as a client or guardian to sign a consent form, assess the skin integrity and provide skin care according to the facility's protocol every 2 hours. Make sure that you're rounding on them and checking if food and fluid is needed and providing it for them. Also provide a means for hygiene and elimination. Monitor vital signs. Make sure they are able to have a range of motion exercises as applicable. Pad the bony prominences to prevent skin breakdown. Use a quick release knot and tie to the bed frame, not to the side rails. Make sure that the restraints are loose enough. You should be able to put in 2 fingers between the restraints and the client, so there should be enough room for that. So remove or replace restraints frequently to make sure that there's good circulation to the area. Ongoing evaluation is needed. Never leave the client alone without the restraints. Regularly determine the need to continue using the restraints. I paused it. I guess I finished speaking about restraint because I just restarted. Anyway, we finished the first section of management of care. The next one is safety and infection control. And so under that, the subtopic is accident, error, or injury prevention. The first one is medical and surgical asepsis, and how do you care for a client who has a latex allergy? So as you know, medical asepsis is basically it's a clean technique where you're trying to reduce the number of microorganisms, number and spread of microorganisms. But surgical asepsis, you are very careful. You use precise practices to eliminate all microorganisms from an object or area and prevent contamination. So that is a sterile technique, and medical asepsis is a clean technique. So what we need to remember, particularly when a patient has latex allergy, is that the healthcare team members need to check if any of them have latex allergies, and if they do, then they need to use latex-free gloves. The equipment, the supplies, all of that needs to be latex-free. So it's very important to assess if the patient has this latex allergy and then use latex-free gloves, supplies, or equipment. Going on to, I don't know if they're talking about hand hygiene later. I don't think so, but even in practice questions, I've seen that how hand hygiene is so important to prevent the transmission of infections. It's the best technique to prevent transmission of infections. And as you know, you need to wash, at least scrub for 15 seconds for you to have a complete procedure of hand hygiene completed. If you're using an alcohol-based product, you want to use about 3 to 5 ml of that alcohol-based rub in your hands, and make sure it completely dries, and then your hand is clean. And then, of course, if your hand is soiled, you definitely want to wash hands. And also in C. diff, if a patient has C. diff, you definitely want to wash hands. You can use alcohol-based product. Going on to the next one, client safety fall risk precautions. That is in 57. So that's about how you need to identify if a person is at fall risk and take precautions. So I'm sure you have in the clinical setting, you may have come across the fall risk assessment tool that they use. They use different kind of scales or tools, Morse, Hendricks, and there are different kinds of fall risk assessment tool. So it's important that at admission and at regular intervals, like every shift, they do a fall risk assessment to identify and see if a patient is at risk for falls. And once they identify that, they need to make sure that they implement the interventions for preventing fall or the precautions to prevent falls. So make sure that the patient has a call light in hand, and they need to respond to call lights immediately in a timely fashion. The patient, when they're at fall risk, many hospitals have different protocols. They have a color-coded wristband. They have a light outside the door, which tells that that particular patient is, for example, a solid yellow may indicate that the patient is at risk of falls. They need to have adequate lighting in the room, make sure that the bed is put in low position, and that the assistive devices and other necessary things are kept close to them, within reach. And especially if they are sedated, unconscious, or otherwise compromised, then their side rails can be up. But if they are able to get out of bed, do not put the side rails up. Provide non-skid footwear, use gait belt and safe equipment while transferring patients or moving patients. Make sure the floor is clean, dry, and free, and keep assistive devices nearby. For example, if they're using walker or cane or eyeglasses, make sure all of them are within reach. I mentioned it before as well. So especially older clients are at risk for falls. I think that's coming up later. So it's important that we particularly take all precautions to make sure that they do not fall. Next one is about nutrition and oral hydration. So it's identifying priority findings following a stroke. So that's the theme of the question. And I think this is in a different chapter. So it's very important that you understand that a patient who has had a stroke may have swallowing difficulties. because when they come to the hospital, and they know that it is a stroke, they do kind of a swallow test. And if the patient fails it, then the patient is put on NPO. It's a very simple test that the nurse can even do it. And of course, later on, they are referred to speech language pathologists, but a nurse, usually they do a test when to see if the patient is conscious, if the patient doesn't have other risk factors, and they test and see if the patient can swallow without any difficulty. So what I'm trying to say is that they have difficulty. Many of them may have dysphagia. They have difficulty with swallowing, so we need to assess that and prevent aspiration. So that is definitely a priority. Position them in a foul-less position. Make sure that when the client stuck their chin when swallowing, this is about safe swallowing. No use of straws. Check if they are pocketing their foods, or they are coughing or choking or gagging or drooling when they are trying to eat. So all of that can indicate that they have difficulty in swallowing. And also the speech language pathologist may slowly advance the diet, like they already thick liquids are easier to swallow than thin. And also they may start on the consistency of the food could also be ground or pureed before they go on to a soft and regular. So it's primarily checking and preventing aspirations following a stroke. Going on to safe medication administration and error reduction. So first of all, we need to be very careful to prevent any medication errors. But if there is a medication error that has happened, then we need to know what needs to be done. So the common medication errors are giving either a wrong medication or an incorrect dose or a wrong client, or giving a medication that the patient is allergic to, omission of a dose or giving an extra dose, incorrect discontinuation of medication or IV fluid, inaccurate prescribing. So these are all the different errors of medication administration. So if there has been a medication error, then it needs to be immediately reported to, because corrective measures need to be implemented immediately. So an incident report needs to be submitted within the specified time frame. Usually it's 24 hours, and make sure that you explain the patient's identification, the time and place of the incident, an accurate account of the event, and then what you did about it, who you notified, what actions you took, and your signature. And of course, as I have explained before, do not reference or include this report in the client's medical record. The incident report is filed separately, and that is a process that we have to do, but you don't have to say that in the client's medical record, reference it. So also this needs to be, if it's related to the process or a system, then the risk management personnel need to know about this so that they can prevent further errors from occurring. And it will definitely improve patient safety. So that's about acting following a medication error. Going on to nursing action when a client falls. We already talked about how to prevent falls, or how to assess if a patient was at risk of fall. But if a client falls, then it's something similar to what I just discussed now. It's very important to document, but before that, you want to ensure that you've assessed the patient, you assess for injuries, right? And then definitely you want to document, report, and so that further similar incidents can be prevented too. Of course, different hospitals have different policies about what to do when a client falls. They'll have immediately huddle and go over the factors as to what led to the patient falling. There's a post-fall risk assessment again done, and now it may be the score may be different because the patient fell. So a fall risk assessment is done after a fall again, and of course immediately assessing for injuries and intervening appropriately is very essential after a client falls. Okay, I think that was an easy question. 88% have got it right. So I guess you should be fine. The next one is about ergonomic principles. It's about teaching a caregiver how to avoid injury when repositioning a client. So this is about repositioning a client. And so there are things that you need to remember when you're positioning clients, especially those who are unable to move themselves. You need to put them in a good body alignment, and frequent position changes definitely prevent pressure ulcers, prevents contractures, discomfort, nerve circulatory damage, and stimulate postural reflexes and muscle tone. So there are different assistive devices that you can use. You can use pillows, bath blankets, hand rolls, boots, splints, trochanter rolls, ankle support devices, and other aids to maintain proper body alignment. And so you definitely need to use these to position the clients. Now, there are your book also states about, but I think these are some principles that you want to remember when you're positioning. But what you also need to remember is about how you need to position the client in different positions. In semi-Fowlers, the head of the bed should be 30 or 45, and it definitely prevents regurgitation of enteral feeds. Also helps with lung expansion. Of course, Fowlers or orthopneic position is best for better lung expansion. But again, for some patients, it could be semi-Fowlers too. There are semi-Fowlers. Fowlers is 45 to 60s. High Fowlers is up to 90. Supine is when the client is lying on his back with his head and shoulders on a pillow. Prone is when he's lying on his abdomen. Side lying is again, they can be on a side lying, but again, if they are pressure ulcers, it's good to put them on a side lying position and turn them frequently, and 30 or less degree position is better. Orthopneic is best for a patient who's having difficulty with breathing. Tredelenburg, of course, it's modified. Before they would use this as to improve circulation and venous return, but now it's a modified Tredelenburg that is commonly used. So these are some positions. There's also Sims and reverse Tredelenburg. But again, these are the different positions, but what you want to remember is see if the patient is positioned well and safe and in good body alignment, with good body alignment. And if there is a need for you to use assistive devices, please use them and position them in the right manner. What else? Prevention of personal injury when lifting. Yes, that's important because we definitely need to safeguard ourselves. And when you're lifting, you want to use the major muscle groups to prevent back strain. And also tighten the abdominal muscles to increase support to the back muscles. So these are some principles you want to remember when you're lifting. Use major muscle groups. Distribute your weight between the large muscles of the arms and legs to decrease the strain on any one muscle group. When lifting on an object from the floor, flex your hips, knees, and back. Bring the object to thigh level, bending your knees and keeping your back straight. Stand up while holding the object as close as possible to your body, so that the load is to the center of gravity to increase stability. And use assistive devices or take help as needed. And also, that's something about when you're lifting something, but you want to prevent injury, definitely plan ahead for the activities such as transferring a patient or ambulating a patient, remove the obstacles in the environment, explain the process to the client and the assistants to make sure they know how they'll be assisting you with, and see what is the safest way to lift a patient. Now they do have different mechanical lifts which you can use, and so try to use those equipments. And again, rest between heavy activities, maintain always good body mechanics, good posture, and exercise. Exercise pretty much regularly to make sure that you have good strength in your arms, muscles, and abdominal muscles and legs and back. And keep your head and neck in a straight line with your pelvis to avoid neck flexion. Use smooth movements when lifting. So these are some guidelines that are there. I think it's in page 71. You can look at the guidelines to prevent injury when you're lifting. Going on to home safety. Home safety is, again, there's a lot of things, but I think what they're particularly asking is seeing if the client understands about home safety and how will you teach an older adult client about home safety. So okay, so there are different elements in a home safety plan, and it's important that the clients know that you need to keep emergency numbers near the phone for prompt use in the event of an emergency. Make sure that you know the number and placement of fire extinguishers and smoke alarms, and see if they're adequate and they're operational. Have a family exit plan for fires that is reviewed and practiced regularly. Review with client of all ages about what to do in case of fire and the mnemonic stop, drop, and roll. And review oxygen safety measures, especially if patients are using oxygen at home, then they cannot be smoking. Nobody around that area should be smoking. Electrical equipment should be in good repair and well grounded. The bedding, replace bedding that can generate static electricity. Keep flammable materials away, and follow fire safety. And particularly for older people always have age-related changes, and so many of them do live independently too, but you need to prevent any injuries or any safety hazards. And so you want to be careful in modifying the home to improve the home safety. You need to understand that they have changes in their cognitive and sensory. A decrease in tactile sensitivity can lead to burns. They may be impaired vision or hearing, and changes in their musculoskeletal, in their alertness and how fast they can be, about their frequent trips to the toilet at night because of nocturia. And so, having all this in mind, we need to remember that the throw rugs cannot be there, loose carpets cannot be there, need to be removed. Extension cords and electrical cords needs to be placed well against the wall or behind the furniture. Monitor gait and balance and provide assistive aids as needed. Make sure that the steps and sidewalks are in good repair. Place grab bars near the toilet and in the tub or shower. And use a non-skid mat. Place a shower chair in the shower. And provide a bedside commode if needed. Make sure there's adequate lighting. So all of these are things that you need to teach clients about home safety and make sure that they are looking into all of these aspects. They understand how important it is for them to have a safe home and also modify their home to what we discussed now. Next one is about reporting of incident. It's an action when a visitor reports a fall. I think what primarily we need to remember is when you're documenting that somebody's had a fall, you want to document how you really found the patient, not what a visitor said. You want to go and assess and see how you found the patient and see what injuries the patient had, or when you went in, how you found the patient, and then what happened. You could also state about what happened, and all of this needs to be documented. So that's what's important to remember. And again, many of them got this right from before, so I think it is not a very hard question to answer. Client safety. Alternatives to restraints for a client who's confused. So, yeah, what would you do for a patient who is confused? So, if a patient is confused, you need to remember that they need to be reoriented periodically, and also providing regular toileting will also help them. So because most of the time it's them trying to go to the bathroom when they do have a fall, or they try to harm themselves because they want to meet one of their needs. So making sure that their needs are met on a periodic basis, having a schedule, and having regular toileting, and also reorienting them. All of this will definitely are alternatives to restraints. If you're frequently monitoring them and checking them and making sure their needs are met, you will definitely be able to reduce restraints use. And also, if you think that there's a need, then a restraint can be applied with the doctor's order. But if not, these are some of the alternatives to restraints. Okay, the next one is, so we talked about safety and infection control. So we can go on to health promotion and maintenance. I don't know if I should stop for a bit.